Praveen Peddu. Thank you so much. Dr. Praveen Peddu is a senior consultant in King's College in London. He was originally a surgeon, but decided to do interventional radiology. He is also a pioneer in IRE, irreversible electrophoresis, and he actually introduced it in the UK health system, as far as I know, in 2014, I think. So we are so pleased to have him with us today to talk about his experience in IRE. Thank you.
Thank you so much for that introduction, Dr. Ahmed Kamel. It's great to be back here in Egypt for the second time. My topic is interventional radiology in colorectal liver metastases and how do we choose. This is quite a complex subject. It's quite a lengthy subject as well. I'll try to run through the options and look at some evidence as we go through. So just some stats to start with. Colorectal cancer is the third commonest cancer in Europe and also the rest of the world. About 20 to 25% of the patients have liver metastases at presentation. 50 to 60% of patients develop liver metastases during the course of their disease. Systemic therapy still remains the backbone for treatment in metastatic colorectal cancer, and modern systemic therapies are now achieving a 5-year median survival of 30% in some trials. The problem here is the duration of response. The duration of response is often limited, and eventually all of these patients do develop chemoresistance, and that's where I think local regional therapies play an important role. Now, I did mention that surgery is the mainstay. Surgery still remains the mainstay, and it's got the evidence to show that this is the best form of long-term survival for patients with those who have resectable metastatic colorectal cancer. The 5-year survival rate after a surgical resection is about 50%. But the problem is only 10 to 20% of the patients are suitable for surgery. And 80% of the patients also develop relapse in the liver after surgery over a period of 10 years, and majority of them do so in the first 2 years. Hence, again, the need for local regional therapies in those group of patients as well. Now, are there any therapies we can offer from an interventional standpoint that can allow more patients to have surgery? There are. Liver venous deprivation or portal vein embolization are now very well established treatment regimes that we can offer to ensure more patients can benefit from surgery. Particularly when they're thought to be having low volume future liver remnant. For example, in this particular patient who's got large volume disease in the right lobe, also going well into segment 4, encasing the middle vein. So he will be left with a very small volume segments 2 and 3. His segment 1 will also be removed. So again, we can modify the liver volume by doing extended liver venous deprivation. The other problem is when these patients have had 2 to 3 lines of chemotherapy, their liver becomes very, very fatty. So the quality of the future liver remnant is subject to question. So another reason why extended liver venous deprivation or liver venous deprivation are important to ensure that the functional volume of the future liver remnant could be improved before surgery. So this is an example of a patient who's got bilobar metastatic disease. You can see that there is disease in the right lobe, and there is also this large metastases within segment 4 as well. So this is a patient who has shown some response. He shows some size reduction. His segments 2 and 3 remain disease-free, so we elected to do extended liver venous deprivation in this patient. So when we do extended liver venous deprivation, what we tend to do is we occlude the portal vein using a combination of glue and lipiodol, and we occlude all the hepatic veins, all the venous outflow through using Amplatzer vascular plugs. And that's exactly what we did. And you can see that the portal vein is occluded, and also the main right hepatic vein, the accessory right hepatic vein in segment 6 is occluded, and also the middle hepatic vein is occluded as well. Okay. And by doing so, we managed to grow the volume of the FLR, and the patient went on to have a successful extended right hepatectomy. And this is the CT done 6 months after the extended right hepatectomy, showing how significant volume hypertrophy there is in the FLR. So what is the evidence base for ELVD? There is significant evidence base. There is a large volume, both prospective and retrospective studies, including a randomized trial recently showing that extended liver venous deprivation is a very effective and very safe tool, not only increasing the volume but also increasing the function of the FLR. So again, something we all have to take on board. There are in certain patients who's got bilobar disease, when the FLR has got low volume metastatic disease, you could use a combination of ablation followed by resection as well to ensure that those patients can go ahead and have liver resection. So again, I'm sure that's very common here as well. Where do these loco-regional therapies come into play? I think most of these come into play in patients who are not suitable for surgery. Patients who may have comorbidities that might sort of stop them from having surgery. Patients who've got bilobar disease but demonstrating suboptimal response to chemotherapy. Patients who have extrahepatic disease with metastatic disease in the lungs or the lymph nodes are also not surgical candidates. And patients who develop recurrence in the liver after surgery. You can broadly divide the loco-regional therapies into two sets of categories. The first one being the ablation. We have both thermal ablation and non-thermal ablation. Non-thermal ablation mainly is in the form of IRE these days. And ablation is often applied when the patients have got low volume disease and they're responsive to chemotherapy. The intra-arterial therapies like chemoembolization and radioembolization are often reserved for patients who've got larger volume disease and who have suboptimal response to chemotherapy, mainly in the palliative setting, almost as a kind of a third-line treatment. Not to forget, there is an option of external beam radiotherapy as well, but the evidence base for that is significantly limited, so I'm not going to really discuss that here. Loco-regional therapies, just looking at thermal ablation. Thermal ablation is considered radical therapy, meaning almost curative for patients with low volume disease. Among all the thermal ablative techniques, RFA has got most evidence, followed by microwave ablation. And the evidence so far suggests that tumors which are less than 3 centimeters have the best response, and the maximum tumors that can be treated in one session can range between 3 to 5. But margins are critical, and the evidence again shows that people who have managed to get margins of at least 6 millimeters, ideally more than 1 centimeter, have got best chance for long-term progression-free survival. Here is one example of a metastases in segment 4 of the liver, which was treated with two microwave ablation needles just to get the ablation zone, and that's the post-treatment CT demonstrating a good ablation zone with good margins. So what is the evidence base? There are a number of large volume studies that have been published in the last 20 years. Majority of the studies initially were from RFA. And I think I'll draw your attention to this study by Solbiati Group in Milan, which is a retrospective study which treated 202 patients with RFA, 202 lesions with RFA. Mean lesion size was 2.1 centimeters, and the number of mean lesions that were treated were 2 lesions. And they reported a good median overall survival of 53.2 months. Subsequent to that, there are 2 studies which looked at microwave, often demonstrating slightly better outcomes. I'll draw your attention to this study, which is again quite a large study of 193 patients with 456 ablations, and they treated patients with both microwave and RFA. And what they have demonstrated is slightly better 5-year overall survival with microwave compared to RFA. Something for us to factor in. I think, generally speaking, I think microwave has now replaced as the ablation of choice for liver lesions at least. There is also a meta-analysis which was published in 2018 looking at the outcomes following ablation and comparing them to resection, and it's sort of given mixed messages. So what it did say is that obviously a partial hepatectomy is superior to RFA alone, but not superior to RFA and combination of RFA plus a partial hepatectomy. This is all pretty difficult to sort of draw conclusions because the outcomes are often subject to the factor that majority of the ablations were performed in patients who are not suitable for surgical resection. But this is a very encouraging trial which was published literally at the beginning of this year. This is called the Maverick trial by the Scandinavian group. This is a prospective multi-center cohort study comparing overall survival in patients with colorectal liver metastases that are suitable for liver resection and that are treated with stereotactic microwave ablation. Stereotactic microwave ablation is using microwave ablation using needle guidance software and also post-ablation mapping software. So that is what we mean by stereotactic microwave ablation. They treated tumors up to 5 tumors and tumors up to 3 centimeters in maximum diameter. And they treated 98 patients in this study and matched to 158 patients in the control group. The 3-year overall survival with stereotactic microwave was comparable to liver resection. In fact, very slightly better. The estimated overall 5-year survival rates were also comparable. That is very important. And also, the important factor is that overall complications after stereotactic microwave ablation were significantly lower compared to surgery, which is again not a complete surprise. And also, hepatic retreatments were more frequent in patients who had microwave ablation compared to those who had surgical resection. Just look at the non-thermal techniques. I think among the non-thermal techniques, probably IRE is the most commonest of all. It uses high voltage electricity to damage the tumor, so which means that it's safe when you treat tumors close to an important structure like a portal vein, hepatic vein, bile duct. So this is one example here. This is a patient, and I'm not sure how well it projects, but there is a tumor in segment 2, which is very ill-defined. And there is also other disease in segment 4, peripherally, and there is another lesion in segment 7, very peripherally as well. We elected to treat all 3 lesions in the same sitting. We treated the segment 2 tumor sitting next to the portal vein with IRE and the other 2 small tumors with microwave ablation. We placed 5 needles within that segment 2 tumor, and this is the post-procedure, immediate post-procedure CT, which shows that, not just the left portal vein, but also the left duct, which is running close proximity, is also undamaged by the treatment. And you can also see the microwave ablation to the other 2. So you can use a combination of these techniques depending upon the location of these tumors. What is the evidence base for IRE in colorectal liver metastasis? I would say the evidence base is limited. I think there are a number of studies, but they're all sort of mostly case reports, small numbers, studies with small numbers. But I'll draw your attention to Martijn's study in 2021. This is the Martijn Meiring's group from Amsterdam, which came out in the year 2021. They treated 51 patients, and they reported a overall survival of 2.7 years after IRE. So encouraging results, but often we're lacked by level 1 data or large volume data to really back that up. Let's switch to intraarterial therapies now. Intraarterial therapies are predominantly indicated in non-resectable liver-only or liver-dominant metastases that are non-responsive to systemic therapy. The idea is to achieve local tumor control, downstage the tumor burden, and they can also be combined with either other systemic therapies or local therapies. Again, there is a mixed evidence. In the European literature, we have a combination of both drug-eluting beads with irinotecan and also a combination of conventional chemoembolization, that is using Lipiodol combined with cisplatin or other drugs. This is one of our examples of a patient whom we recently treated. This is probably one of the best examples, actually. You don't always get this. This is a 60-year-old chap who's very fit, but who wasn't responding to 2 lines of conventional systemic chemotherapy, large volume bilobar disease. And we treated him in 3 sittings, doing a staged, Debiri treatment, treating the right lobe first, then the left lobe, and then again coming back and treating the left lobe again. And this is the post-treatment CT, 6 months after 3 cycles, followed by PET scan, showing significant response, not significant response in terms of downstaging the disease, reducing the volume of the disease, and also you can see the PET scan as well showing a significant metabolic response. So it does work, but again, you don't always see that sort of response, but so that's one of my best examples. So what is the evidence base for TACE? There are a number of literature studies, lower numbers, some of them with large numbers, but they project a overall survival that ranges between 9 and 21 months when used in the palliative setting. There's one study which looked at using chemotherapy, conventional TACE in the neoadjuvant setting that showed a slightly better overall survival. And what about Debiri TACE? Shows again similar outcomes, probably slightly better, and the overall survival ranges between 19 months to sort of 37 months, so slightly better perhaps. And again, when used in the neoadjuvant setting, again showing slightly better overall survival as well. So just to summarize regarding TACE and colorectal metastases, there is no head-to-head comparison. There's no level 1 data to say which one is better, but both can be equally good, I suppose. But what is one thing is there are some studies which show a combination of conventional chemoembolization and ablation can offer better long-term response. But having said that, both the European and the American bodies only recommend use of intra-arterial therapies only in patients who have failed systemic chemotherapy as a third-line option, really. And they don't really recommend using it in any other setting, particularly in the neoadjuvant setting, unless it's done as a part of a clinical trial. Let's come to radioembolization lastly. Radioembolization for HCC has changed significantly in the last sort of 2 to 3 years, but it still remains not the modality of a choice. It's just largely because there is lack of robust data to support it, but it's mainly used in the palliative setting. And again, both the European and the North American societies, organizations only recommend using it as a palliative option in patients who have failed systemic chemotherapy. There are 2 products currently available. There's resin and glass microspheres. And this is the evidence for that when used as a salvage procedure. Both the resin spheres and also the glass spheres offer an overall survival of 10 months when used in the palliative settings in patients who failed with 2 lines of chemotherapy. What about its use as a first line? It has been tried. There are 2 trials which came out in 2016 and 2014 using radioembolization in combination with systemic chemotherapy in unresectable disease, and both of them did not demonstrate an improvement in PFS. So both of them were actually in fact negative trials. So as of now, there isn't any evidence for its use as a first-line option in unresectable disease. Having said that, radiation segmentectomy is something which we are doing more and more in HCC patients. This is something now being considered in colorectal metastases patients as well. But the challenge is that these tumors are hypervascular, and the vascularity also changes significantly because of the chemotherapy. But we can use a cone beam CT, which is now available widely, to target these lesions. The evidence base for this is limited. There are a few studies, mainly in the form of case reports, using a mixed cohort of metastases from all over the place, without any major survival benefit, actually. So the evidence still for that is lacking, I have to say. This is one patient who we treated with radiation segmentectomy. This is a chap who recurred after a partial hepatectomy. Unfortunately unsuitable for repeat resection, and he demonstrated limited response to chemotherapy as well. He couldn't tolerate chemotherapy, and this was his early site of disease. We did a radiation segmentectomy using cone beam CT targeting that area, and this is the post-treatment PET scan, which shows a deposition in that area, and he tolerated the treatment well. I don't have the follow-up CT on this case, but it's something which is now being considered as a special resort in patients who are not suitable for other options. To summarize, a response to chemotherapy remains a critical factor in evaluating local regional treatments. Surgical resection, I have to say, still remains the gold standard. Optimizing patients with liver resection, ELVD, ablation should be considered in patients who've got a good performance score. And stereotactic ablation is now gaining more and more popularity both in Europe and in North America in patients with oligometastatic disease, and particularly the trial which I said gives us encouragement to do that more often in patients with low volume disease. Radioembolization and TACE both can be offered mainly in the palliative setting as of now, in patients with liver-dominant disease. To conclude, colorectal liver metastases are a mixed heterogeneous group of patients, and for them to be, for local regional therapies to be considered, the treatment planning has to be done in the tumor boards where there is expertise available, expertise in the form of surgery, oncology, both radiation and medical oncology available, so that these patients can be put in the appropriate pathways, because the treatment options are very, very complex. And not to mention that not everywhere, not all centers have all these treatment options available. So treatment options vary depending upon the local expertise as well. So that's the other factor, that other thing to factor in as well. Currently, there's no standardized strategy that can be applied for a combination interventional therapies and other treatments. Thank you so much for your attention.
Again, discussion at the end of the session. Thank you, Professor Dr. Praveen, for your interesting presentation. And now I may invite